This conference will now be recorded.
Hello. My name is Dr. Rumen Hitchev, a VP and Chief Science Officer of the American Association of Tissue Banks. And I'm here to talk about the COVID-19. That's the disease caused by the virus, codenamed SARS-CoV-2, from severe acute respiratory syndrome caused by the coronavirus, second generation. I'm going to talk about the epidemiology, pathophysiology, diagnostics, and clinical highlights of the disease and the morphology, reproductive cycle, tissue, and cell distribution of the virus. I am also a staff liaison with the AATB Physicians Council, Scientific and Technical Affairs Committee, and the Standards Committee. So some of the aspects of the issues that I will talk about today will have direct implication onto the standards developed by the association. First, just to make sure that the code name that I use is understandable, COVID-19 again stands for coronavirus disease identified in 2019. The motto of the presentation is, "In God we trust, everyone else brings data." It comes to emphasize the importance of data. All the information that will be presented today is based on validated data and peer-reviewed publications. What you're looking at right now is our microscopic picture of public enemy number 1 right now. This is an enhanced scanned electronic microscopy of the SARS-CoV-2, the virus that causes the disease. What's causing a lot of concern about medical professionals relating to this disease is its really a non-specific clinical picture. There is a good reason why we call it the phantom of pathology, because the clinical presentation of this disease is so non-specific, so broad, that it presents real difficulties in diagnosing that disease. 25% of the people who are infected with this virus show no clinical signs, but they spread the virus. 50 to 55% have some moderate symptoms, and 20 to 31% develop serious symptoms requiring hospitalization. 5 to 12% develop critical condition requiring intensive care, and unfortunately 3 to 5% succumb to the disease. The most common clinical picture is typically an infection of the upper respiratory tract and the lower respiratory tract, presented as pneumonia in most of the cases, but in some cases the leading complaints are cardiovascular, including acute hypertension, arrhythmia, viral myocarditis, acute cardiac failure, and in some cases the leading symptomatology is related to the gastrointestinal tract, including diarrhea, nausea, vomiting, sometimes hepatobiliary complaints, biliary dyskinesia, elevated liver enzymes, including also neurological complaints like dizziness, disorientation, and some skin complaints. All age groups are affected by this disease. Unfortunately, there are no prognostic algorithms, and in 60 to 70% of the infected individuals, it is determined that they contracted the virus from someone who has been asymptomatic or pre-symptomatic, which the whole picture comes to tell us that the diagnosis of this disease presents extreme challenges to the medical professionals, and this is why we have tried to analyze the pathophysiology of the virus, because it helps to explain why such broad spectrum of complaints and symptoms. This is another scanning microscopy of the virus, a 3D enhanced scan microscopy. And The morphology and the protein structure of this virus put it in the category of enveloped viruses. It's an envelope positive sense single strain RNA virus, meaning that its RNA can function both as a genome and as a messenger RNA. Its size is between 70 to 90 nanometers, which is about 1/1,000,000th the size of a tennis ball. It consists of a lipid membrane, membrane protein, envelope protein, neuraminidase protein. The neuraminidase protein is also presented on the envelope of the flu virus, and it causes the muscle ache, the body aches, the headache. It also has a nucleocapsid protein that envelopes the RNA of the virus, a so-called spike protein, which is a very important protein because it serves as a key that the virus uses to unlock the doors to the cellular membrane. This microprotein that's on the top of these spikes surrounding the membrane of the virus performs this function as a key to unlock specific receptors on the membrane of the cell, and open the door to penetrate the cell. The name of the virus, coronavirus, comes from the appearance of these spikes that look like crown, and from Latin, crown is corona, so hence the name of the virus, coronavirus. And it also has a single strain RNA inside the virus. As I mentioned, it uses its microprotein located at the tip of the spike, uses two receptors to unlock the doors of the cells. The first being an ACE2 receptor, and the second being a CD147 receptor. ACE2 comes from angiotensin converting enzyme 2 receptor, and CD147 comes from cluster of differentiation 147 receptor. These receptors are connected to specific enzymes on the cellular membrane. The ACE2 receptor is an ectoenzyme which is expressed on the surface of various cells, starting from the upper respiratory tract and going all the way down to the lower respiratory tract, esophagus, the myocard, biliary tract, resorptive enterocytes in the ileum, the small intestine, the colon. And CD147 receptors are presented at the surface of the T lymphocytes. These are immune cells. The viral RNA is typically absorbed by a lysosome in the cell when the virus connects to these receptors, and is transported to the ribosomes of the cell, where the replication of the virus takes place. Once infected, a cell can produce up to 3 million copies of the virus. This process ends with the apoptosis, which is the death of the cell, when the virus leaves the cell. And this is the picture of a cell. This is a culture, by the way, of pneumocytes, where the virus has been cultivated. It now leaves the cell, rupturing the cellular membrane. And in this process, the virus takes a part of the membrane with it and goes into the intracellular space, the interstitium, to reach other cells and infect them. How the virus gets into the body, that's usually happens through the upper respiratory tract, through the nasopharyngeal mucosas. Once the virus gets into the mouth or the nose or the eyes of the individual, it infects the local cells, again using the ACE2 receptors on the surface of these cells, and then through inhalation while coughing or sneezing, it goes down to the lower respiratory tract, and specifically to the alveoli, where the cells that the virus predominantly attacks are located. the virus has a specific tropism to cells lining up the inside of the alveoli called pneumocytes type 2. These cells produce a very important substance called surfactant. The surfactant, and we will explain how that happens, keeps the alveoli open in the process of inhaling and exhaling, and keeps the alveoli from collapsing or sticking in a collapsed status after the exhalation of the air. So this is how an alveoli looks like. It's like a system of small balloons that looks like grapes connected, with each one of these balloons being placed into a basket, into a network of capillaries. Capillaries are delivering the blood that gets oxygenated through the air, through the oxygen delivered with the inhaled air, and releases the carbon dioxide into the air that's going to be exhaled. Inside each capillary, there are again pneumocytes type 1 and pneumocytes type 2. Pneumocytes type 1 are responsible for the gas exchange. They're taking the oxygen from the inhaled air and delivering it into the blood, and they're taking the carbon dioxide from the blood and dumping it into the air that's going to be exhaled. So these two cellular types are very important for the main function of the lung. But let's see what's going on inside the cell once the virus gets there. So this specific slide is to show the inside of a cell called pneumocyte type 2. And let's say with some dose of imagination that this is the cell. This is the cell. And the virus comes from here. This is the virus, the blue shaped form. Comes here, uses the ACE2 receptor on the surface of the cell as a key that opens the door to the receptor. Then the virus goes inside and gets engulfed by an endolysosome. The endolysosome is something like a stomach for the cell. Each cell has multiple lysosomes, and they usually engulf different substances and deliver them inside the cell. Now, these endolysosomes have enzymes in them. So once the virus gets engulfed in an endolysosome, it gets subjected to the action of these enzymes in the lysosome. And these enzymes dissolve the capsule surrounding the viral RNA. So the viral RNA it gets released during the transportation of the virus inside the endolysosome to the ribosomes of the cell. The ribosome apparatus of the cell performs various functions, but once the cell gets infected by the virus, these ribosomes turn into production factories, figuratively speaking. These production factories have two production lines. The first one makes copies of the viral RNA, millions of them. And the second production line makes proteins that are needed for the viral replication. This process is made possible by a specific enzyme called RNA-dependent RNA polymerase. This virus needs RNA-dependent RNA polymerase for its replication. So it's one of the segments that is targeted by the medications that we have developed. Now, once the RNA-dependent RNA polymerase gets into action, you get millions of copies of the viral RNA produced, and then millions of polyproteins needed by the virus. But these polyproteins cannot be used for assembling a virus. They need to be broken down to simple proteins, and this is done by a virus, by an enzyme called protease that breaks down the polyproteins into simple proteins. So eventually you get millions of copies of the viral RNA and millions of simple proteins that can be used to assemble a virus, to build the different segments and the different parts of the virus into one whole virus. So when the viruses are ready, they leave the cell, breaking the cellular membrane, taking part of it with them, and going to infect other cells. However, this process doesn't go unnoticed by the cellular, by their immune system. The cells release exosomes that send signals to the immune system that something wrong is going on. And on site, we have macrophages and neutrophils arriving on site and releasing specific substances designed to attack the intruder. Unfortunately, this action is non-specific. The neurophages and the neutrophil, or the macrophages and the neutrophils are part of the so-called non-specific immune response. So they shoot everything around and release specific substances called mediators of the inflammation. The first one being interleukin-1, the second interleukin-6, also tumor necrosis factor alpha, and other mediators of the inflammation. And these substances are causing the permeability of the capillaries that are surrounding the alveoli to increase. When you have increased capillary permeability, you have liquid leaving the capillaries and going into the interstitium, the intercellular space, and from there going inside the alveoli. So you have edema and you have alveolar effusion, a liquid inside the alveoli. When you combine the effusion, the liquid in the alveoli, with the fragments of the destroyed cells because of the infection, you get a liquid that's consolidating and eventually is causing the clogging of the alveoli. In addition, because pneumocytes type 2 have a main role of producing surfactant, and here we're going to jump for a second to the next slide to explain what is the surfactant and what role the surfactant plays. But before that, we have to explain let me delete this first. Before this, we have to explain how the surfactant works inside the alveoli through the prism of the Laplace law. Under the Laplace law, when we have when we look at the alveoli, there is pressure in each alveolus, and the pressure is equal to 2 times the surface tension and divided by the radius of the alveoli. Now the question is, where does the surface tension come from? The surface tension is caused by a liquid, aqueous liquid, that covers the inside of the alveoli. Its role is to prevent the alveoli from sticking at the end of the exhalation of the air. So this liquid has molecules in it, and they're attracted to each other. So they cause the wall of the alveoli to a tendency to collapse, to go inside. And this force is counteracted by the pressure of the air inside the alveolus. So at one point, the pressure inside the alveolus and the surface tension caused by this liquid equalize, and the alveolus remains open. The role of the surfactant that is produced by the pneumocytes type 2 is to reduce the surface tension, to reduce this figure here in this equation. So what happens when we exhale the air? The radius of the alveolus becomes smaller. So when you have a smaller radius, you get a smaller denominator, which translates into a higher pressure. When you have a higher pressure inside the alveolus, the air that you inhale, instead of going to the alveolus with a higher pressure, it goes to the alveolus with a lower pressure, because that's the natural tendency of the air. It goes to the place either with vacuum or with lower pressure. So now the role of the surfactant is to keep this equation in a way that the pressure inside the alveoli is lower. So let's go back to this slide and explain why there are clogging of the alveoli and the lower level of surfactant and the debris inside the alveoli causes a problem. Because when you have less surfactant, more debris inside the alveoli, more liquid inside the alveoli, what's the result is that the alveolus collapses, and the liquid inside it consolidates. And this, in this way, you get the pneumocytes type 1 involved. When you get the pneumocytes type 1 involved in this collapse of the alveoli, the pneumocytes type 1 cannot perform their function, and their function is the gas exchange. So the lungs cannot breathe. They cannot perform their main basic function. And what does this? What is the end result of this process? In the worst case scenario, it leads to SARS, severe acute respiratory syndrome, because the lung cannot breathe. SARS on its turn leads to SIRS. What's SIRS? This is a systemic inflammatory response syndrome. The systemic inflammatory response syndrome also leads to septic shock. And when one gets in a septic shock, there is only one step to multi-organ failure. And the multi-organ failure is what causes the death of an individual who is unlucky to have developed this most severe complication of the COVID-19. Thank God these are a small minority of the cases, but this is a very severe condition that has a very high mortality. Now, how can we counteract the virus, and where are the weak segments in the virus's cycle of reproduction where we can attack it? Well, the first one is the action of the enzymes inside the endolysosome. If we suppress these enzymes, it's going to be more difficult for the viral RNA to get released from its capsule. And that's where the hydroxychloroquine is acting, or chloroquine. It inhibits the action of the enzymes inside the lysosome. Another drug that comes to consideration in COVID-19 is the remdesivir. This antiviral drug, which was developed during the years of Ebola as an antiviral drug used to treat Ebola, it inhibits the action of the RNA-dependent RNA polymerase, the enzyme that's used in the ribosomes to replicate, to make copies of the viral RNA. So remdesivir inhibits this enzyme. There is another antiviral drug, a combination drug between lopinavir and ritonavir, commercial name Kaletra, that inhibits the action of the protease that breaks down the polyproteins to simple proteins that can be used for building the virus protein structures. Now we can also influence and suppress the immune this part of the immune system that exacerbates the inflammation response, which has detrimental effect. A drug that inhibits interleukin-1, an inflammatory mediator, is anakinra. And another one that inhibits the interleukin-6, and interleukin-6 is the most aggressive inflammatory mediator, is tocilizumab, commercial name Actemra. It inhibits the action of interleukin-6 so that the inflammatory response is not so severe to lead to type 1 pneumocyte damage and SARS and septic shock and multi-organ failure. So we explained the invasion of pneumocytes type 2. Now let's explain how the invasion of T lymphocytes happens, because T lymphocytes are very key, very important immune cells. When the virus approaches the T lymphocytes, it uses its CD147 receptor as a lock to unlock the door to the membrane of the T lymphocytes. Again, CD147 stands for cluster of differentiation 147. This is a specific receptor on the membrane of the T lymphocytes. When the viral gets inside the T lymphocytes, however, it is not able and cannot replicate as it does in the other types of cells where the virus uses the AC2 receptor. So the virus gets into the T lymphocytes but cannot replicate there. What the virus does is it tricks the T lymphocytes into activating a system for apoptosis. This is an automatic regulatory system that destroys excess T lymphocytes when, after an infection, we have produced more T lymphocytes that we need. They commit suicide, programmed suicide, through this process called apoptosis. So the virus has found a way to activate this process and to prompt the T lymphocytes to commit suicide, apoptosis. And this is why one of the leading signs of COVID-19 infection is lymphocytopenia or lymphopenia, which is a decreased count of the lymphocytes. It's a very typical sign of COVID-19, and it's explained through this segment of the viral pathophysiology. How can we counteract this action? There is a drug called meplazumab, which is a humanized monoclonal anti-CD147 antibody. So these antibodies block the receptors used by the virus to unlock the door of the T lymphocytes. The protocol of treatment is 10 milligrams of meplazumab IV at days 1, 2, and 5. Now let's take a look at the ACE2 receptors, because they're extremely important in explaining the pathology of this virus. We know that many patients with COVID-19 develop extremely high blood pressure, hypertension, go into suppressed cardiac activity or in cardiac insufficiency, and they die because of cardiac complications. Why is this so? Because the virus using the ACE2 receptors interferes with the function of one very important cascade system in the body called the renin-angiotensin-aldosterone system. This is a system that regulates not only the blood pressure, but also the immune response and the inflammatory response. It starts with a single substance called angiotensinogen, which is subjected to the action of a specific enzyme produced in the kidney called renin. So that angiotensinogen is turned into angiotensin 1. Angiotensin 1 is then subjected to the action of another enzyme called angiotensin converting enzyme. It is produced in the lungs. As a result, we get angiotensin 2. And angiotensin 2 is very important in this whole cascade because it causes an increased production of aldosterone in the suprarenal glands. And the aldosterone, on its turn, causes a decrease in the potassium levels and increase in the sodium levels. This causes an increase in the blood pressure. Now, each one of us has a natural predisposition to being in one of two possible groups. The first one being the group of people with low levels of angiotensin 2, and the other one, a group of people with high levels of angiotensin 2, depending on the action of the ACE enzyme. If we are lucky to be in the first group, the group of low angiotensin 2, this cascade process goes through a receptor called angiotensin converting enzyme receptor 2. And going through this receptor and getting connected with the angiotensin converting enzyme, the angiotensin 2 gets converted into a very important substance called angiotensin 1,7. Why is it very important? Because it causes vasodilation, which means lower blood pressure, and less inflammation, which means lower inflammatory response. And these are good, very good results. We want to be in this group. How this process takes place is through a specific combination between the ACE2 receptor and another receptor called angiotensin receptor 1. So the ATR1 receptor and the ACE2 receptors are connected. The ATR1 receptor is connected to the catalytic zone of the ACE2 receptor, which keeps the ACE2 receptor active, which makes it possible to process more AT2, more angiotensin 2, thus decreasing the level of angiotensin 2, which is good, and producing angiotensin 1,7, which is the good substance, the one that we need. So this configuration of connected, locked ATR1 and ACE2 is a good configuration. You want to be in this configuration, locked NTR1 and ACE2, locked together. Now, what happens if we are unlucky to be in the other group, a group of folks with elevated angiotensin 2? When the angiotensin 2 is elevated, it splits this connection between ATR1 and ACE2. And when these two receptors are split and separated, you have space between them, which is exploited by the virus. The virus can now get in between the two receptors and lock into the catalytic zone of ACE2. Once the virus locks here, you get a complex, this complex which is surrounded with this red line. And this complex is then engulfed by the endolysosome and transported to the ribosome to start the replication of the virus. There is another negative effect, detrimental effect of this separation of the two receptors when the angiotensin 2 is high. Because when the ACE2 receptors are separated, this allows the angiotensin 2 to go, instead of the ACE2 receptor, to go to the ATR1 receptor and to go through a different metabolic process. And the end result of this different process is a detrimental one. Vasoconstriction, elevated blood pressure, increased vascular permeability, pulmonary edema, and eventually ARDS, acute respiratory distress syndrome. How did we find and validate these conclusions? There were laboratory experiments on lab animals, and in these animal models, mice, we knocked out the genes that are responsible for producing ACE2 enzymes. And these genes were knocked out on both sides, on both parents. So the offspring does not have ACE2 receptors at all. It's called a double knockout. And what do we see in the mice in this group? We saw elevated angiotensin II. We saw a decrease in the myocardial contractility, which means weaker heart. We saw high levels of aldosterone. And we saw that these mice are prone to respiratory distress syndrome. So this explains why the virus causes sharp increase in the blood pressure in people who are infected by it. When we gave these mice a synthetic ACE2 produced through monoclonal methods, these symptoms disappeared, which comes to prove that the role of the ACE2 receptors is very important. Now, people who have high blood pressure usually take specific medication that falls into two groups. The first group of drugs that are taken for high blood pressure is the group of the so-called angiotensin converting enzyme inhibitors, or AC inhibitors. These drugs usually, the names of these drugs usually end with pril, like enalapril, captopril. So if you see pril in the end of the name of the drug, it's in this group, AC inhibitors. Another medication that's taken by folks with high blood pressure is the so-called angiotensin receptor blockers, or AR blockers. Their generic names usually end with sartan, like losartan and others. They always end with sartan. The AR blockers, what they do is they block both of these receptors, both the ATR1 and the AC2, into one, and don't allow their separation. So in this way, they achieve two goals. One is to keep these receptors locked and not allow the virus to get to the catalytic zone of AC2. And the other positive effect is that it keeps the AC2 active so that the metabolism of angiotensin II goes through the AC2 and not through the ATR1, which is the bad path. So the AR blockers have this positive effect. What has been found in patients who have been taking these medications for years is that nature tends to compensate for these artificial influences that these medications do, and people who take AC inhibitors and AR blockers for years tend to have a higher expression of the ACE2 receptors. So in the beginning of the pandemic, when we started treating patients with COVID-19, the initial impression and recommendation was to stop the AC inhibitors and AR blockers, because we were afraid that the multiplication, the higher expression of ACE2 receptors, it would provide the virus with more doors to unlock and to use to get into the cells. However, with deeper analysis, the European Association of Cardiology reached to a different conclusion that even if we stop the AC inhibitors and AR blockers, We are not going to eliminate this end result, the higher elevated expression of ACE2 receptors, but we will deprive the patient from the beneficial protective effect of these two drugs, namely to keep the angiotensin II lower and to keep the receptors ATR1 and AC2 locked together, thus preventing the virus from access to the AC2 receptor. So the updated recommendation now, which was first announced by the European Association of Cardiology and was then upheld by the American Association, is that these drugs should not be discontinued in patients with COVID-19 because they have a protective role. Another drug that has some influence on this process is the hydroxychloroquine. It is believed that it inhibits the action of another enzyme called serine protease, which facilitates the process of locking between the virus and the ACE2 and creating this complex between the virus and ACE2 that's engulfed by the endolysosome. But this action has to be additionally validated, and there is another drug that's currently under specific clinical trial that is expected to inhibit the serine protease. So this is the role of the ACE2 receptors, and this is how the virus influences this intricate system of regulating the blood pressure, the immune response, the inflammatory response, and it also explains the various symptoms of this disease. Now, that if we know which cells have ACE2 receptors and how the ACE2 receptor expression is distributed on the cells in different systems and organs of the body, we will be able to predict which are the cells and organs that are vulnerable to attack from the virus. Here on this slide, you can see a normal lung tissue. These are the alveoli, and so this is an alveoli. This is another alveoli. This is another one. This is a normal lung tissue. Then, if you look at a little higher elevation, higher magnification, you can see, and we have used here a specific stain that emphasizes the ACE2 receptors. So these darker colors indicate the presence of an ACE2 receptor. Again, this is the door that the virus uses to get into the cell. This cell here is a pneumocyte type 2. And this cell here is a pneumocyte type 1. Let's go to the next, actually the next slide will have a bigger, better magnification, so you'll see more details of these cells. How do we recognize the pneumocytes type 2 from pneumocytes type 1? Pneumocytes type 2 are bigger, they're more have more cuboid shape, and they're positioned closer to the luminous of the alveoli. And the pneumocytes type 1 are smaller. They're usually located in the proximity of the capillaries, and this is a capillary here. This is another capillary. So this is the alveoli, pneumocyte type 2, pneumocyte type 1 capillary. You can see that there is also staining inside the capillaries, which comes to show that the capillary endothelium has higher expression of ACE2. Now, this is, let's get rid of these marks. So this is a sclerotic lung. The sclerosis is caused by the infection. These are the cells, pneumocyte type 2. And you can see that the expression for AC2 is higher with pneumocytes type 2 at the inside of the alveoli. Here on slide E, you can see a cellular culture of pneumocytes type 2 with a typical cubical shape, larger size. And slide F represents lung tissue stained with anti-ACU2 stain, which shows no AC2 expression. These are the same slides at bigger magnification. Again, pneumocyte type 2, pneumocyte type 1, papillary, alveoli, sclerotic lung, pneumocytes type 2 cultured. What other tissues have AC2 receptors and are vulnerable for the virus? The oral mucosa. Here is the epidermis. Here is the basal layer of the epithelium. Here is the subdermal part. And these are the vessels that have higher expression of AC2. Both their capillary endothelium and here the capillary smooth musculature have higher expression of AC2. Also, the basal layer of the epithelium here also has higher expression of AC2. Slide B shows the small intestine, an ileum, with its typical villi. You can see that the borderline of the villi, and here on the bigger expression, it's more visible that the borders of the villi have higher expression of AC2. Also, the muscularis mucosa has high expression of AC2. And also the muscularis propria, which is the muscular part of the wall of the intestine, also has high expression of AC2. This is another section of the submucosa, also clear expression of AC2. And this is a section of the colon, main expression of AC2 in the capillary vessels. It's visible here. And this is a slide that's where an anti-AC2 stain is used, so there is no staining. What other tissues can be affected because they have higher expression of AC2 receptors? The skin tissue, this is normal slide. Here you can see that the eccrine glands of the tissue have very high expression of AC2 receptors. Here you can see that the basal layer of the epidermis has higher expression, and this is a hair follicle. Also, there is a higher expression of AC2 receptors around the hair follicle. This is a higher magnification showing the AC expression at the basal layer. This is a slide of brain tissue. An increased expression of AC2 receptors is visible in the endothelium of the capillaries and also the smooth musculature of the vessel. Slide B is liver tissue. You can see that the vessel walls, the vessel endothelium has higher expression right here of AC2. Also the bile ducts right here. However, in the liver, there is no AC2 expression in the Kupffer cell hepatocytes and the endothelium of the sinusoids. They're negative for AC2. This is spleen tissue. These are the immune cells in the spleen tissue. There is no AC2 expression there because, as you remember, the lymphocytes have CD147 receptors and not AC2 receptors. And the higher expression is only seen in the vascular red pulp and sinus endothelium. This is a kidney. This is a kidney. This is the glomerulus of the kidney. We can see higher expression on the visceral epithelium of the glomerulus and the parietal epithelium of the glomerulus, and the distal and proximal tubular cells right here. This is the distal and these are the distal and proximal tubuli of the kidney. So in all these slides, you can see that how broadly expressed ACE2 receptors are, and how many organs and tissues are vulnerable to the viral attack. Now, the current pandemic is not the first time coronavirus is attacking the human population. The first time in history has been proven to have taken place in the early 12th century. How did that happen? How did they find that this is the case? A 7-month-old child in the Netherlands in 2004 was treated for severe bronchiolitis, and the researchers and doctors in the Netherlands isolated the infectious agent, which was a coronavirus. They did the genomic sequence, and they did a comparative analysis of the viral genomic sequence compared to the human genome. Similar in the way utilizing the technology that's used these days for tracing back our ancestors. Where did they come from? Where did they live? So the Dutch researchers found out that the first time this viral genome and the human genome clashed with each other in the early 12th century. The virus code name is HCOV-NL63, NL from Netherlands, the place where this virus was first identified. Nowadays, this virus causes lower respiratory tract infections, croup pneumonia, and in approximately 5%, and is the agent in approximately 5% of the common cold cases today. The second time a coronavirus clashed with the human population was in the early 19th century, human coronavirus 229E alpha. Both these viruses, actually all of the coronaviruses, fall in the category of so-called anthropozoonosis. That means that these viruses circulate in the animal kingdom and occasionally jump into the human population. Their primary reservoir is the bat population. Bats are the primary reservoir. Occasionally, the virus uses an intermediary host before jumping into the human population. So HCOV-229E alpha started from bats and used the camel population as an intermediary host. Today, this specific strain of the coronavirus causes 35% of the common cold cases. The third case when coronavirus infected the humans was in late 19th century, but this time the primary reservoir of the virus was cattle, cows. So which comes to tell us that any animal in the animal kingdom can serve as a primary reservoir for a virus to cause a pandemic among humans. And we must be ready to counteract to any future virus that would try to do something like that. So this virus was codenamed HCOV OC43 beta, came from cows, second half of the 19th century, developed in several genotype strains, A, B, and C. Today, they cause the common cold, and the D strain, which today causes pneumonia in older patients. The fourth time coronavirus is causing headache. It was in 2003 in modern time. Again, the primary reservoir was bats. Intermediary host was civet cat, and the mortality rate of SARS, severe from severe acute respiratory syndrome was 10%. The next epidemic was in 2012-2013, when the Middle Eastern respiratory syndrome took place, MERS. Again, primary reservoir bat, intermediary host camel, and the mortality rate MERS was 30%, very high. The current pandemic is caused by the SARS-CoV-2 virus, and the primary reservoir is again bats with a middle host, intermediary host pangolin, with a current case fatality rate of 3 to 5%. Besides the coronavirus, the flu viruses are also cause pandemics. The first pandemic described in 1918, the so-called Spanish flu. In 1918, most of the European countries were involved in World War I and did not announce, actually kept the fact that hundreds of thousands of their citizens and soldiers were dying secret. Spain was the only country that did not take active military, active participation in military activities, and it was the only state that raised the alarm and informed about this epidemic situation, and that's how the name Spanish flu remained in history. The next pandemic was in 1957, the Asian flu, caused by the H2N2 strain. In both occasions, the primary reservoir was the domesticated birds. In 1968 was the next pandemic caused by H3N2 strain. Again, the primary reservoir domesticated birds. The Hong Kong flu. 1977, the Russian flu, and 2009, the swine flu. These points here identify mutations that have been identified and documented so far. There are two types of flu virus, type A and type B. Influenza A is the type that causes pandemics and more severe complications. Attacks primarily older people. And influenza type B, two lineages, Victoria and Yamagata, only circulates in the human population, has never caused pandemics. The complications are less severe, and it attacks primarily young people. The timeline of events related to the current pandemic started in early December 2019, when the first cases of atypical pneumonia caused by an unidentified infectious agent virus came out on December 10, December 11, several cases, then again December 13, December 14, and these, and again December 16, with the number of cases increasing. But during this period of time, the Chinese government was suppressing the information, and the physician who raised the alarm was reprimanded and intimidated. Dr. Li, later on, he was the first physician who lost his life to the coronavirus. So he's respected now as not only as a physician who sacrificed his life in treating patients with coronavirus, but also as the first physician who raised the alarm about the impending threat to mankind. This information was received through the epidemiological intelligence at that time. There were no official Chinese government announcements during these years. Later on, December 26th and December 22nd, There are no new cases identified. One of them, 3 members of the same family with severe atypical pneumonia, prompted the local medical authorities to take action. They informed the central authorities in Beijing, and they traced down these cases to a local animal and seafood market in Wuhan. Next step is that they shut down that market. On January the 7th, they identified the agent causing the disease as coronavirus of new novel type, hence the novel coronavirus. And just several days later, on January the 12th, they decoded the genome sequence of the virus. A couple of days later, the decoded genome sequence was shared with other countries and with the World Health Organization, so that it was possible to start mass manufacturing of tests for the virus. The first country outside China that created the first test was Germany. In mid-January, they created the first test outside China. Unfortunately, the tests that we tried to create through in the CDC in the United States, the initial version came out defective, so we wasted, lost valuable time, and the testing and the broad-scale testing was delayed. On this timeline here, you can see the gray columns indicate identified diseases, and the yellow columns indicate confirmed COVID-19 disease. On January the 24th, they imposed their shutdown. They shut down Wuhan, and a couple of days later, they imposed isolation measures upon 16 other cities in the province. And as you can see, the decrease in the number of newly identified cases and the decrease in the number of confirmed cases followed almost immediately, which comes to prove the positive effect of social distancing and isolation measures. In the beginning, there were 2 approaches toward the pandemic. One was the so-called passive approach, to allow the pandemic to develop, to take its natural course, so that we can acquire the so-called herd immunity when a certain percentage of the population is infected and goes through the disease. Then the curve of the new infections go down naturally. However, when they did the calculations, they found out that implementing this approach would inevitably lead to vastly exceeding the capacity of the healthcare system and would lead to millions and millions of human deaths. So this concept was abandoned, and another concept was adopted, the concept of taking measures to limit the spread of the infection early on and spread it through time, so that the capacity of the healthcare system is not exceeded. This graph shows the explosion-like increase in number of cases outside China. South Korea in the beginning was with the greatest number of new cases, Italy, Iran. Later on, however, and this shows the increase in newly identified cases, including China. We can see that in the second half of January, the number of cases started increasing. With to the end of January, it reached 20,000. A very substantial, very fast increase in number of cases. So experts raised the alarm at that time that this epidemic has real chances of becoming a pandemic. Now, we can see that South Korea managed to gain control on the pandemic situation, and they achieved that through mass testing, early screening testing, so that they identified a great percentage of asymptomatic or pre-symptomatic carriers. They took measures, and they managed to substantially decrease the number of newly identified cases relatively early with minimal losses. Now, this is one of their many models that exist. I like this particular model because of its user friendliness. It's based on several metrics that are always used to control a pandemic. First one is the population, of course. The second one is the number of initial infections. And this is a very important metric called basic reproduction number, or R0. It measures the capacity of every next viral generation to infect certain number of immunologically naive people who do not have immunity. And with the coronavirus, this number is somewhere between 3 and 3.5, which means that every individual who is infected can infect 3 other individuals with the virus. The next metrics is the length of incubation period. It's relatively, it's approximately 5.2 days. The duration when that patient is infectious, it's more than 2.9 days. It's actually roughly approximately 5 days, because that's when usually patients are identified as infectious. And actually in the United States, with the delayed results from the testing, I've heard states where the results from coronavirus testing come out a week later, which is unacceptably long period of time, considering that technically the results are available within 24 hours. Even utilizing the RT-PCR, which is the test that takes more time. Another very important metric is the case fatality rate. Case fatality rate is the number of infected individuals who lose their lives as a result of the infection. And the current number, based on the numbers today, is over 5%. There are several other metrics, but I would just mention another very important metric, which is the serial interval. The serial interval is a metric that measures the time between the first symptom presented by an infected individual and the time when the first symptom is presented by the next individual infected by this one. So this time with index with coronavirus is 5 days. The lower this index is, the easier it is to gain control on the pandemic, and the smaller it is, the more difficult it is to control a pandemic. And this model here shows what would have happened in the United States had we adopted the initially recommended approach by someone that do nothing, or don't care, it's a hoax, it's alarmist stuff, so don't be alarmed. Had we taken this approach, we would have had over 10 million dead Americans when this thing was over. So thank God this idea was abandoned. Now here we have some statistical information, the mortality rate among different age groups. Like for example, there are elderly folks over 80 years of age have 15% mortality rate. Folks between 70 and 79 years of age have 8% mortality rate. 60 to 69 years, 4%. 50 to 59, 1.3%. And younger folks below 40 years of age, 0.4%. Below 39, 0.2%. So you can see that in the case fatality rate of the common flu is 0.1%. So you can see that this is substantially higher mortality compared to the flu. Comparing to the flu is exactly like comparing a tiger to a cat. They're both in the cat family, but there are some minor differences. So folks who compare coronavirus with flu are comparing cats with a cat with a tiger. If we look at the statistics on March the 21st, we had 305,000 infected individuals globally. March 17th, yesterday, we had 2,183,000. On March 21st, we had 13,000 deaths globally. Approximately 1 month later, 148,000. You can see how fast this pandemic is expanding and how serious it is. So here we can see the difference between the capacity of ICU beds in the United States and the demand that would occur in the scenario of taking no measures. And this is the demand for hospital beds. You can see the difference, and self-explanatory. These are the points of identified mutations of that virus. You can see how many times that virus has mutated. Right now, there are two main strains of the virus, the strain type L and type S. The type S is the ancestral chain, the ancestral strain of the virus. It is less severe, has not so severe complications. And the type L, the strain that came out of the ancestral strain, type L, was curiously the strain that caused the epidemic in China. So it started with the daughter strain, not with the ancestral strain. Why are these points of mutations important? This is because, if you remember, each cell that's infected makes up to 3 million copies of the virus, and each and every time when there is a replication of the virus is playing a game of bingo and is hoping that it's going to hit the jackpot, because every time when there is a replication, there is a chance that there will be a mutation or a spontaneous change in the viral genome that will allow the virus, because most of these mutations involve the S protein, that microprotein that's on the tip of the spikes of the virus, that the virus uses as a lock to unlock the doors to different cells. So every time when there is a replication, there is a chance that the virus will get a mutation that will allow it to open more doors and more receptors and infect different cells and more organs and systems into the human body. So that's why suppressing the transmission of the virus is so critically important. If we continue to neglect their isolation measures, and these isolation measures only make sense if they're simultaneous in the entire United States, including all states, not this patchwork that we currently can see. This patchwork that we currently can see is makes no sense, no epidemiological sense. It will achieve nothing. So these measures only make sense if they are simultaneous, comprehensive, cover the entire territory of the country, all states, and only then we can achieve the results that we want to achieve. Otherwise, if we have this patchwork of measures, this will only prolong the epidemic, the pandemic situation, and results will not be as good as we would like them to be. This slide comes to show the process of transmission and how the one infected individual can infect 2 or 3 other individuals that can affect other folks, and this way the virus is spreading to the human population. The different tests that are used are 2 types: serological tests that measure the presence of immune cells in the circulation. These are typically immunoglobulin M and immunoglobulin G, and sometimes immunoglobulin A. These tests are very inexpensive. One test costs approximately $3. They're sold easily in Europe. You can buy them if you'd like, and you don't need a lab. You can do it yourself at home by using a lancet. You just need a drop of blood. So I place a drop of blood in a specific spot on the plate and a couple of additional drops of medium, and that's it. And then you see, it's like they're a pregnancy test, and then you can see the test lines. If the tested individual only has elevated IgM, that means that he was infected approximately 5 days to a week before. If there is only a line for IgG, that means that the individual was infected a long time ago. He probably had very mild or no symptoms and has some level of protection at this point. If both IgG and IgM are positive, then that means that the individual is in the middle of the infection and they got infected somewhere approximately 15 days ago. And if there are no symptoms, that means that the immune system has found the most effective, the optimal balance to, on the one hand, fight the virus, but on the other hand, to not cause the inflammatory response complications. This slide shows the timeline of the immunoglobulins. They start to emerge in the circulation approximately on the 5th day after infection and continue to raise all the way until the 15th, 17th day. IgG is the immunoglobulin that remains longer elevated and indicates immune protection, and IgM and IgA usually emerge in the circulation earlier, and they get lowered earlier. This is how RT-PCR test equipment looks like. This is the other type of testing, the so-called diagnostic testing. This test identifies the viral genome into the mucosis of the throat and the oropharyngeal mucosis. The specimens are obtained through swabbing using cotton swabs to swab their oropharyngeal mucosis, and then you put the swabs into a cartridge and into the machine, and you get the result on the next day. Now there are also express kits developed, the so-called COVID-19 ID Now RT-PCR that give results within 5 to 10 minutes. Now this is the clinical approach, the treatment approach. There are three groups of patients. The first is the group of patients showing almost no symptoms. They can be left at home and monitored from a distance. The second group of patients is patients who are presenting with more serious symptoms and require hospitalization. The first line of drugs that is used includes statins, Crestor mainly, 20 milligrams. It started almost automatically. Remdesivir, 200 milligrams IV, followed by 100 milligrams IV for 5 to 10 days. If it doesn't help and the symptoms continue to develop, then IVs very carefully to avoid lung edema, antipyretics, antibiotics according to the need. Again, statins, Crestor, and hydroxychloroquine. The hydroxychloroquine is started with 400 milligrams twice a day, followed by 200 milligrams twice a day for 1 to 4 days after that, in combination with azithromycin, 500 milligrams twice a day for 5 days. Here, you must monitor the QT interval on the EKG, because one of the serious side effects of this combination is it has a cardiotoxic effect, blocking their impulse of the heart electric system, which is demonstrated by an increased QT interval. If the interval gets over 500 milliseconds, then you have to terminate this drug combination and switch to chlorohine phosphate or Rezuhin, 500 milligrams twice a day, followed by for 5 days, or lopinavir ritonavir combined antiviral drug, commercial name Caletra, 400 milligrams over 100 milligrams twice a day for 10 days, or a combination drug, the darunavir cobicistat, also called DRV/C, or commercial name Prescobix, 800 over 150 milligrams a day per day. RDV8 is another drug which is falls in the group of the 4-deoxypyrimidine drugs. It has an anti-inflammatory and immunomodulatory function. If these medications don't work, then last line of defense is using interferon beta B1, commercial name Betaseron. However, they have severe side effects and have to be used very carefully. Could be combined with hydroxychloroquine and or Caletra, lopinavir, ritonavir. And if there is a cardiorenal syndrome or signs of cytokine storm, which is the most severe complication of the disease, then tocilizumab comes into consideration. As if you remember, tocilizumab is a drug that blocks interleukin-6, which is the most potent inflammation mediator. And also anakinra can be used. It blocks the interleukin-1, which is also an inflammatory mediator. This is again their slide that explains the levels where these drugs work, different levels of their viral replication cycle. Now, if the patient needs to go to the ICU for intensive care, there is a very new approach that was developed in Europe by an Italian physician, Dr. Gattinoli, who works in Germany. And this approach is widely accepted now in the United States. They, in treating thousands of patients, they found out that COVID-19 does not automatically mean ARDS, acute respiratory distress syndrome. Most of the COVID-19 patients, and specifically those patients who are identified earlier, present with respiratory insufficiency of first type, which is hypoxemia, but without hypercapnia, meaning normal carbon dioxide. So these patients have a higher compliance of the lungs, lower elastance, lower ratio of ventilation over perfusion, usually less than 4/5 liters per minute, lower lung weight, and lower recruitment potential of the lungs. This is very different to ARDS. And in the beginning, by just copy-pasting the Chinese protocols, physicians in the United States tend to treat all patients with COVID-19 automatically as if they have ARDS and recommend early intubation. But once a patient is intubated, you have to deal with a whole other set of complications that make it much more difficult to manage the case. So this is determined that intubation should be very carefully assessed as a course of action and not be rushed toward intubation. So these patients, the first group, presenting in respiratory insufficiency type 1, were identified as phenotype type L COVID-19. Now, patients who have been sent back home and neglected, or patients who failed to seek qualified medical care and showed up in the hospital late in their disease, usually present with respiratory insufficiency type 2, which is presented with hypoxemia and hypercapnia, meaning increased carbon dioxide and severely reduced oxygen level in the blood, usually under 55 millimeters of mercury. And these are very different groups. Again, the first group has higher compliance, the second group has lower compliance of the lungs. First group has lower elastance, second group has higher elastance. First group has low lung weight, second group has higher lung weight. First group has lower recruitment potential of the lungs, the second group has higher recruitment potential of the lungs. And they require different treatment strategies in the ICU. In the beginning, these patients were put all together and treated in a one-size-fits-all approach. So it was not obviously the most effective and the most result-producing way. In the first phenotype, type L, we can afford to have a little higher tidal volume, 7 milliliters per kilogram of the patient. In the second group, it's not recommended. In the second group, it's recommended to have lower tidal volume, not more than 4 to 6 milliliters per kilogram body weight of the patient. In the first group, we can keep the respiratory rate at 20 per minute, not too high. In the second group, it's recommended to keep the respiratory rate higher than 20 per minute, because with the lower tidal volume, you tend to cause hypercapnia, increased carbon dioxide. And this on its turn leads to higher pH, which means respiratory acidosis. Respiratory acidosis may cause other damage to other organs, so we need to keep control on this. In the first group, you can have permissive hypercapnia and still keep the pH over 7.25. And in the first group, you can have a little lower PEEP, that's positive end expiratory pressure, at 3 to 5 centimeters H2O. But in the second group, you need to keep the PEEP higher, in any way more than 5 centimeters H2O, usually between 8 and 16, because these folks have higher recruitment potential of the lung, higher elastance, lower compliance, and keeping the PEEP higher means that you can prevent the alveoli from further collapsing, or you can try to open already collapsed alveoli, while with the first group, they have lower elastance, higher compliance, so you don't need to do that. You don't need higher PEEP. Actually, higher PEEP in the first group can cause damage. And last but not least, both groups can benefit from positioning the patient in prone position. But in the first group, you can go straight to positioning them in prone position with no recruitment. In the second group, you have to keep them in the supine position in the beginning until you conduct your calculation for the lung recruitment potential, and this is strictly recommended. Never initiate lung recruitment before calculating the percentage of the lung that's available for recruitment. Otherwise, you're going to do more damage than benefit. So these are the most recent strategies. This is the strategy, again, it was implemented in Europe, and it's being now implemented in the United States. And this is it's closer to the physiology and the pathophysiology of the disease. Now, for those of you who are having trouble understanding compliance versus elastance, here are some examples. Compliance is actually the ratio of volume over pressure. The more pressure you need to achieve certain volume, the bigger is the denominator and the smaller is the result, compliance. So if you have something like let's take an artery. An artery is a tube with a muscle wall that's more difficult to increase in size by applying pressure. You need more pressure to increase the volume of this tube at certain level, which means that the compliance of the artery is lower. Now let's take a balloon, and the balloon is very close to the alveoli. With a balloon, you don't need much pressure to achieve certain volume. You can apply a little pressure and get a lot of volume, so that's why the compliance of the balloon is higher. So if you want to understand compliance, a balloon has high compliance. An artery or a pipe, for example, has low compliance because you need more pressure to achieve certain volume and less pressure in the balloon to achieve certain volume. Now, what is elastance? Elastance is exactly the opposite. If you have an object where you don't need a lot of pressure to achieve certain volume, it has lower elastance. And if you have an object where you need more pressure to achieve certain volume, it has higher elastance. So in this case, an artery has a low compliance and high elastance, and a balloon is exactly the opposite. The balloon has high compliance and low elastance. And something similar happens in the lungs. If the lungs are sclerotic, damaged by the virus, the patient falls into this group, the second group, type H phenotype, and has low compliance, high elastance, meaning that the lungs are sclerotic, difficult to unfold. While patient in the early stage with typical COVID-19 has higher compliance and lower elastance, meaning that lungs require less pressure to get to be unfolded. These are important aspects for the proper intensive care of a patient in the ICU. And these are the outcomes of some clinical trials of these well-known medications, specifically the hydroxychloroquine, which has been touted as a game changer in the early stages. We all remember when they were announced as the game changer drug. Well, the outcomes of the clinical trial, and this was a clinical trial on 150 randomized controlled patients in this clinical trial conducted in the Department of Pulmonology and Critical Care Medicine in Shanghai. They used hydroxychloroquine at high doses, 1,200 milligrams a day for 3 days, followed by 800 milligrams a day for 2 to 3 weeks, depending on symptoms. They had 2 groups. First one was treated with hydroxychloroquine and standard of care treatment, including antiviral, and the control group was standard of care only. The evaluation was done on the 28th day, and the negative conversion rate, meaning the clearance of the virus, resolution of the viral presence on the 28th date, was calculated using the Kaplan-Meier estimate method. So the result was the hydroxychloroquine group had 85.4% negative conversion rate on the 28th day. The control group 81.3%, with similar rates on day 4, 7, 10, 14, and 21, which is not it's not sufficiently substantial difference to have a conclusive to have a finalized conclusion. The other metrics, adverse events, 30% of the patients in the hydroxychloroquine group had adverse events, mainly diarrhea. 8.8% in the control standard of care only group had adverse events. Mostly in the hydroxychloroquine group, diarrhea in 10% of the patients who had the adverse events. Control group 0%. The alleviation of symptoms by day 28, 59.9% in the hydroxychloroquine group, 66.6% in the control group. However, we must take into consideration that hydroxychloroquine group was also treated with antivirals, which they have some side effects by their own. So it's possible that there was a confounding, because of that effect. I'm sorry. The next metrics was the CRP reduction from baseline on day 28. CRP for C-reactive protein. The reduction was 6.986 milligrams per liter for the hydroxychloroquine group, 2.723 milligrams per liter for the control group, which is not significant because if you consider the cytokine storm or the other serious complications of COVID-19, these differences are usually much higher. So this difference is not considered significant to make a final conclusion. Only mild symptoms on a post-hoc analysis had 20% of the hydroxychloroquine group and 9% of the control group. However, it's not clear whether moderate and severe symptom patients were not removed to eliminate the confounding effect of antivirals, because such patients received antivirals too. Again, the fact that this group received antivirals caused these patients who received antivirals to be removed at the stage of the post-hoc analysis to remove the confounding effect of the antivirals. So this may explain the higher level of only mild symptoms in this group, because the patients who were prescribed antivirals who were removed from the analysis were most likely the patients who presented with more severe symptoms in the first place. And finally, the initial symptoms at the point of recruitment: shortness of breath, in 22% in the hydroxychloroquine group, 5.9% in the control group. Sputum production 16.2% versus 5.9%, and cough 51.5% versus 38.2%, which shows that the patient selected for the hydroxychloroquine group in the beginning of the trial had more severe symptoms. Now, on the remdesivir, we still don't have final results from the clinical trials. They will be available anytime now, but so far we have only preliminary data. Another shortcoming is of this clinical trial is that they don't have control groups, and having control group is very important in order to be able to assess the placebo effect and make other assessments. Patients with medical ventilation at the beginning of the trial were 64% of the patients recruited for the remdesivir trial. Adverse events had none of them. Improved oxygenation achieved 68% of the patients treated with remdesivir. Extubated on the 18-day median follow-up was 57% of the patients receiving remdesivir, and discharged at the 18th day median follow-up were 47%. This is the link of the Gilead manufacturer of remdesivir, showing all clinical trials going on and in real time the results and the parameters. Now, the very new development is that there are signs that the live polio vaccine of Alfred Sabin may have a non-specific protective effect against the entry of the coronavirus in the mouth, nose mucosa. Why is that? Because the live polio vaccine contains a live yet attenuated virus, which is very active, and you take it through the mouth. It's a liquid vaccine that you put in the mouth, and the live polio virus activates a phenomenon called viral interference. So once you take once you have a revaccination of polio, because most of us have, all of us have had the polio vaccination as children. So when you get revaccination, it has been determined that this viral interference phenomenon prevents other viruses from invading the nasooral mucosa, and this may have a preventive effect against the coronavirus. Of course, this is yet to be validated as a hypothesis, but there are very good signs based on previous experience that this will be proven to be the case, and we hope that that will be the case. And with this, my presentation is over. This slide just comes to tell us that social distancing, at least at this point, is the only proven mitigation method so far. And after all, we have to live with what we have available at this point. If there are any questions, I would be happy to answer them. No question.
Hey, Dr. Hitchev, this is Bill O'Brien, work with Alex. Thank you so much for this presentation. I learned a lot, to say the least. One question that I have is this polio situation. How long do they think it will take until they are able to determine, how effective that could be?
It would take at least 3 months, but if the results are validated, I mean, if the hypothesis is validated, it is a very, very promising approach because it will kind of shut the door that the virus uses to infect a human being, because at this point, it is very clear that the virus uses the nasopharyngeal axis and occasionally the eyes as an entry door. And this is the only entry door that the virus has available at this point. Why are we so certain that that's the case? That's because there are cases of blood transfusions in China and elsewhere of blood donors who at the time of blood donation did not present any symptoms, and they donated blood, and then several days later they came up with symptoms and were tested, and it was proven that they're infected with the coronavirus, but at the time the blood was already transfused. So there are 11 cases of blood transfusions from coronavirus infected patients in their active phase, and none of these 11 blood recipients converted, had seroconversion, and none of them developed coronavirus symptoms. None of them actually contracted the disease, which comes to tell us that despite the fact that there are cases, actually many of them, regardless of the severity of the disease, in both lightly ill patients and severely ill patients, there is the so-called viremia, meaning the presence of the viral genome in the blood, and also the so-called arenemia, meaning fragments of the viral genome in the blood. And despite of this, there are no described cases of transmission of the virus through blood transfusion, which comes to tell us that the mouth, the nose, and the eyes are the main entry door the virus uses. And if we have this way, and the polio virus is a well-known virus, particularly the attenuated virus, it is a very active, very territorial, yeah, probably this is the best word to characterize it, territorial virus. Once you put a live polio virus in your mouth, it quickly invades the mucoses, and it does not allow, actually it wipes out all other viruses, and it shuts the door to all other viruses to invade the mucoses. There were experiments, and this the person actually who is the proponent of this project is a physician. His name is Dr. Chumakov, who is one of the associate directors of the FDA right now. He's of Russian Jewish descent. His parents came to the United States from the Soviet Union at the time, and they were in the team of Alfred Sabin, who was the creator of the live polio vaccine. So even from his childhood years, he was very familiar with the development of this vaccine and intricately familiar with the characteristic of the virus. So this information comes from him. He said that several times when they revaccinated themselves with the polio virus, because of the nature of their work, is heading their research and development, vaccine development lab, the FDA and the CDC, and has been exposed to all kinds of pathogens. So they use this this revaccination, live polio revaccination, as a protective means to protect themselves from these various pathogens. And before applying the vaccine, they took samples from their urine samples, stool samples, saliva samples from themselves, and tested them, and they found that normally every one of them had some viral presence, like adenoviruses, rhinoviruses in their saliva, urine, etc. But once they did the revaccination with the live, yet attenuated poliovirus, and then they tested again on a follow-up, all other viruses were wiped out. There was only the polio virus. And there is another interesting thing about the live polio vaccination is that, which is taken through the mouth. It's not an injection form. It's taken, you put it, it's a liquid, you put it on a sugar and you suck it in your mouth. Once this revaccination is done, you can the positive effect can be transferred to your to members of your household. This is so territorial and so active is this virus. So if for example you take this virus, you put these drops in your mouth, or a piece of sugar, and have this oral reimmunization with poliovirus, and you go back home, the members of your household will also be immunized without ever touching the vaccine. This is very curious because this virus will jump from you on them and will immunize them. And because it's an attenuated virus, it is genetically modified to deprive him from the capacity to cause infection. So he only activates the immune system and the non-specific immune protection. The only downside, by through reimmunization of yourself, you can also reimmunization of your members of your household. The only downside of this is that you have to have normal intact immune system. If you have a suppressed immune system, if you're on chemotherapy, if you're on radiation therapy, if you have other reasons for to believe that your immune system is suppressed, or you're a recipient of an organ transplant, then this vaccination is not is contraindicated. You should not use it. And also, if you have members of your household who are with suppressed immune system, you should not use this revaccination. But otherwise, if you revaccinate yourself with the live polio oral vaccine, all other viruses that would commonly be present in your body will be wiped out, and no other viruses will be allowed to enter for a certain period of time. At this point, it's roughly about several months protection. This revaccination gives you several months protection. It could be longer, but the trials are not over yet, so we'll find out when the trials are over. And hopefully this will turn out to be a very successful strategy against the virus.
Great, thank you.
Do you want to keep recording while we're asking questions, or do you want to stop the recording?
No, actually we can stop the recording and oops, let's see.